Okay, good morning, everyone. It is 11 a.m. on the dot right now, so we're just going to jump right in and get started because we have a pretty full agenda and we want to get to it all. So thank you for joining today's webinar, Lighting the Path, a cross-sector response to BC's Mental Health and Addictions Plan. I would like to begin by acknowledging that CMHA BC Division's office is located on the unceded, traditional, and ancestral territory of the Musqueam, Squamish, and Tsleil-Waututh Nations. I would also like to quickly credit our previous webinar presenters, Jenny Morgan and Vanessa Bursick, for the slides you see in front of you. Now, before we launch into the content of today's webinar, I'd like to point out a few features of the technology we're using and quickly run through the agenda. First of all, there are two options for sound. You can listen with your computer's audio or dial in by telephone. If you find that you're having difficulties with one audio option, please consider switching to the other at any point during the broadcast. A friendly tip, if you choose the telephone option, a landline is preferable to a cell phone and will result in clearer sound. Second, we'll be recording today's session and posting the video online at getloudbc.ca, and I'll also be distributing it by email next week. Third, after the panel discussion, there'll be an opportunity for audience members to ask questions. Please type your questions into the question section of your panel to the right. You can do so as soon as they occur to you at any point during the broadcast. The sooner the better, as I'll collect questions throughout the webinar and read them out to the panelists in the order I receive them during the Q&A period. If you would like to address your question to any one panelist in particular, please make a note of this in your submission. We'll try to get to as many of your questions as possible before the end of the webinar. Okay, I'll turn us over to the next item on our agenda and invite our CMHA BC CEO, Johnny Morris, to provide some context for today's discussion of A Pathway to Hope, BC's 10-year mental health and addictions plan.
Great. Well, thank you very much indeed, Amelia. And there, yeah, we can see me sitting there. There we go. Thank you very much indeed for this opportunity. And welcome everyone to this morning's webinar. It's great to see at least 51 of you out there signing in this morning to what I think will promise to be a really important conversation about the province's recent release of their provincial mental health strategy, mental health and addiction strategy, and an opportunity to chart a path forward for what else we might be able to build together moving forward. So my name's Johnny, and I've recently joined the BC division here as their CEO back in May, and in full disclosure was in public service just before that, working in the Ministry of Mental Health and Addictions alongside a number of colleagues who worked across government and with ministers to support the release of A Pathway to Hope. Today's conversation represents, and today I'm fully speaking on behalf of CMHA BC, an opportunity to echo some of the comments I made back after its release on June 26th. The strategy itself represents a significant reorientation in a number of ways to well-being promotion, prevention, and early intervention. And so a focus there on not just crisis services, but also the things we need to put in place as a mental health and addiction system to support people before they become ill or develop severe addiction. A real commitment to responding to the diversity of BC with regard to Indigenous peoples, South Asian peoples, LGBT folks, etc. A focus on integrated and seamless care, as well as an emphasis on key populations like children, youth, and young adults. At the time of the release, when I was here as CEO at CMHA BC, the comments we made were about applauding this reorientation and the actions that are detailed in the plan as priorities over the next 3 years. And there's a number of actions that I think will likely feature at the heart of the conversation today. And I understand that likely the province is really keen to implement those actions as well as possible to continue to iterate and evolve this strategy moving forward. And so that's a really exciting roadmap. And that's how the plan has been characterized, a roadmap for future years over the next decade to really improve mental health and addictions care in the province. Today's conversation also represents an opportunity to think about what else we might need to plan for and integrate. And CMHA BC, in its public commentary, has described opportunities to talk about the workforce here in the province around mental health and addictions, to think about the requirements and needs around really building out a true addictions care system for children, young people, and adults. And also to think about how we can be assistive in monitoring and supporting the implementation of these actions. There's a sentence in the strategy that calls for scrutiny, quality improvement feedback as the plan moves forward over the coming years. And I think today is an opportunity with the panelists that Amelia is going to introduce you to in a few moments to start the conversation of what this document represents as a pathway to hope. And also the art of the possible around what we need to ensure this document isn't the final word on mental health and addictions for the next decade. And I think those of you who are listening in on this call, I know we have a diverse audience this morning, will be great with your questions and your comments this morning to help us get to that future vision as well. So I'll pause here and hand it back to our very skilled host, Amelia Hamfeld, who's a policy analyst. I don't know if you introduced yourself, Amelia, but maybe you did. Amelia, who's the policy analyst here to get the formal proceedings underway. Over to you, Amelia.
Thanks, Johnny. I often don't introduce myself.
I just did that for you.
I appreciate it. I'm normally just the facilitator and the voice behind the webinars. But I am more than happy to introduce our panelists. I'm going to start with Sarah Irving. Sarah has had the privilege over the past few years of working as a peer and supervisor of peers in a variety of different capacities and organizations. She has worked as a peer support worker, has trained and supervised peer supporters, was part of developing a curriculum for youth peer support, and most recently worked for CMHA Vancouver Fraser branch as the program manager of peer services. Sarah is very passionate about people with lived experience, not only working within our mental health and substance use systems, but also shaping the design, delivery, and evaluation of services. Welcome, Sarah. Next, Lesley McBain. She is the co-founder of Mom Stop the Harm and a family engagement lead for the BC Centre on Substance Use. Her work is rooted in lived experience. Lesley lost her only child, Jordan Miller, to a drug overdose in 2014 when he was only 25 years old. Since then, she's become an advocate for more compassionate, evidence-based drug policies, co-founding an organization and leading advocacy efforts that call for harm reduction, decriminalization, and family involvement in the prevention and treatment of substance use disorders, as well as in the policymaking and research process. She has also attended the 2018 United Nations Annual Commission on Narcotic Drugs as a member of the Canadian delegation. Welcome, Lesley. And third, Dr. Cornelia Weiman works for the First Nations Health Authority as Senior Medical Officer, Mental Health and Wellness, and as an adjunct professor in the Faculty of Health Sciences at Simon Fraser University. Nell is Anishinaabe, Little Grand Rapids First Nation from Manitoba, and Canada's first female Indigenous psychiatrist. She completed her medical degree and psychiatric specialty training at McMaster University in Hamilton, Ontario. Since then, her career has included providing psychiatric services at a community mental health clinic, contributing to the development of a national framework addressing First Nations youth suicide, being the co-director of the Indigenous Health Research Development Program, an assistant professor in the Faculty of Medicine at the University of Toronto, a faculty advisor to the Indigenous Students Health Sciences Office at McMaster University, a co-investigator for several initiatives funded through the Canadian Institute of Health Research, and a staff psychiatrist at the Centre for Addictions and Mental Health, and serving on Indigenous Spire Foundation's board of directors and is president of the Indigenous Physicians Association in Canada. Nell has received the Indigenous Spire Achievement Award laureate for career achievement in the category of medicine, was an inaugural recipient of the University of Waterloo's Faculty of Applied Health Sciences Alumni Achievement Award, and received the Queen Elizabeth II Diamond Jubilee Medal. Nell's clinical, academic, and advocacy work has always been focused on improving the health and mental health status of Indigenous peoples, especially Indigenous youth across Canada. Welcome, Nell. Okay, so today's discussion is going to focus on analysis of a pathway to hope's strengths, gaps, and areas of continued advocacy. Since we have limited time, we'll not focus too much on the details of the plan. I encourage you each to read the plan in its entirety if you haven't already done so. A PDF copy is included in the handout sections of your GoToWebinar panel. You can download it at any time during the broadcast and have it on hand for reference. You may have noticed from our panelists' bios that each one is particularly well positioned to speak to one of the plan's 4 priority areas. Sarah will speak to improved access, better quality of mental health services. Lesley to substance use, better care, saving lives. Now to supporting Indigenous-led solutions. The fourth pillar, improved wellness for children, youth, and young adults, will be touched on throughout our discussion. Unfortunately, our fourth panelist, Kelly Anderson, the president and CEO of Family Smart, could not be with us today. So now that we're in the same virtual room together and oriented to the topic at hand, let's start the panel discussion. So the first question is going to be posed to each of the panelists in turn. And Sarah, I'll start with you. Do you see a pathway to hope as a shift in our province's approach to mental health and substance use? If yes, how would you characterize that shift?
Yes, I absolutely think that the plan is, there are many shifts within the plan, and I definitely echo some of the things that Johnny spoke to in introducing this discussion in terms of, I think that it's things that a lot of us know already and feel strongly about, but it's formalized in the plan in a way that I think needs to be celebrated. I think some of the ways that I noticed there being a shift is, as Johnny said, it's focusing more on prevention and not only supporting people when they're in crisis and have acute needs, but also farther upstream. I was particularly excited to see that there is going to be affordable counseling services for folks. I think that that is an example of being more preventative, and I think that that'll make a huge difference in terms of people's well-being, because so many folks can't access affordable counseling or can't afford counseling at all. And so I think that that's an example of becoming more preventative. I think in addition to being more preventative, I think that there's also a shift in the system, acknowledging mental health and substance use in different areas, not only in our formal medical systems, but also in early childhood programs, workplace mental health in schools, support for parents and pregnant folks, and not only in-person care, but also online care. I also noticed, and as you hear from my bio, I'm very passionate about peer work, and I also noticed that there was a shift in terms of people with lived experience needing to lead different parts of our system and seen as integral parts of our system in terms of service providers and also informing the work that we're doing. I also appreciate that the plan acknowledges that our Mental Health Act in this province needs to be improved. And I see that as a shift. I think that all of us kind of informally know that, but it being named, I think, is really important. And I think that integration and access, as Johnny said, and also as the plan said, is really highlighted. And I think that all of us know that those things need to be improved. And so seeing it in writing, I think, makes me feel hopeful.
Thank you for your comments and your acknowledgement of the formalization of some positives about the plan. I'll turn it over to Lesley. Do you similarly echo Sarah's comments in that it is a significant shift? And if yes, how would you describe that shift?
When I read the plan, which I've done a couple of times, it's very hopeful. It has lofty goals. It seems quite complete. Having lived in this world in the world of opioid addiction and overdose deaths for several years now, I see gaps that I hope will be fulfilled or filled in within these few years. And really, I would hope to see them tomorrow, but I know that's not going to happen. Our focus, and when I say our focus, it's Mom Stop the Harm, and our about 1,300 to 1,400 members across Canada now are to see the end of overdose deaths. We work to that goal all the time. What I didn't see in the plan is an acknowledgement of the need for a safe supply of opioids in particular and other drugs rolled out in a regulated, legal, and medical manner so that people who need them can access safe drugs until such time as they choose and are ready to recover. So I'm probably going to end up talking more about the gaps, because I think in theory, the pathway to hope is really good. If we could do all of it, if we could do it in a really timely manner, I'd be very happy. I see that it's going to take reprioritizing of funding. It needs to be nimble. Like I say, it needs to happen now. We need, in particular, well, I can get into the particulars later, I guess. But I see gaps that I'd like to see filled, or I'd like answers to, which I'm sure will be forthcoming. As far as a shift, I see the shift is priority. We all know that what is in this report is what is necessary. So is it a shift? I think it's a shift in seeing it as an important path.
Thanks, Lesley. I'll now turn the question over to you, Nell, and then we'll dive into the gaps that you brought up. Nell, same question to you. Do you see a pathway to hope as a shift in our province's approach? And if yes, how would you characterize that shift?
Great, thank you. Well, I really want to echo both what Sarah and Lesley said. So I think one thing that I find obviously has been mentioned, that the plan is quite extensive, and over the 4 priority actions, Indigenous issues and First Nations issues specifically, from my work at First Nations Health Authority, are, there's an attempt to address the issues in a number of different ways from a number of different angles. But I think to just give a quick summary, I think of what I like or we like about this approach is there's a lot of attention paid to the relationship between the province and BC First Nations people in this example. And there's also mention of relationships with other Indigenous people across the province. Because of my work at First Nations Health Authority, I'll mainly confine my comments to First Nations people in this province. So I think mentioning in a report that has to do with mental health and addictions, when it comes to First Nations and Indigenous people, it's very important to talk about, to set the stage, to establish the relationship. And so there's mention in this pathway of, respecting or working along the principles of the United Nations Declaration on Indigenous People and following through on the calls to action from the Truth and Reconciliation Commission. So, I think that that's a very good way to set the relationship moving forward. And then my second comment really has to do with what Sarah mainly talked about, was the shift in this province from recognizing that, yes, we mainly operate out of necessity sometimes on a crisis basis, but that we need to move some of the attention and services more upstream, so into primary prevention. And this approach is actually very consistent with the BC perspective, the BC First Nations perspective on health and wellness, which I would love to show you a picture of, but it's a very holistic model, right? So it talks about the individual aspects of a person needing to be in balance, things like the mental, physical, spiritual, emotional, but it also extends outward into the values on which our health takes place, the locations at which our health takes place, the determinants of health, including social, economic, cultural factors that affect our mental health and overall health, and as well all the different relationships that we have with people that impact upon our health. So I think those two things, setting the stage through a tripartite relationship, including federal partners with Indigenous people, and this move to think more upstream.
Thank you, Nell. It's clear that the plan's emphasis on prevention and partnerships are key for improving our mental health and substance use systems. Lesley, I'll have you start our gap analysis of the plan. Can you identify what some of the gaps are in both the problems stated and the solutions proposed?
The two big solutions not mentioned here and aren't necessarily within the purview of provincial government is, as I said before, safe supply and decriminalization of people who possess illicit drugs for personal use. These two steps are not mentioned and are not given any space. And we know that these two steps will go a long ways to, in the crisis mode. We are in crisis mode. So while I'm very happy to see in the plan the upstream attention to young folks, I would like to see, there's a program called Preventure that I happen to know that was created in Canada and I think in Montreal by Patricia Conrad. It's a pathway to identifying kids who might down the line be at risk for risky behaviors. It's a beautiful, simple program. It could be used easily across the country. Things like that are solid and doable and not tremendously expensive. So yes, I totally agree that we need to prevent and to support people in their youth. However, some of the gaps that are killing people are inadequate numbers of recovery facilities that are supervised, that are regulated, that are evidence-based and professionally run and are subsidized. If we had those, all those priorities for facilities, for people to recover, that would be a huge step. Also, the number of beds that we actually need at any given time. And I know these are tall orders, but do we want to solve the problem? Of course we do. And so these things have to be implemented. And again, it's funding priorities. It is the will to put money and put the money where our mouths are, or the opposite, whichever, to do these things. We need to support the people who are using drugs right now to be able to get where they need to go without dying.
Thanks, Lesley. I think you brought up some really important points there, and it's really about timely implementation and funding priorities. And I was going to pass it over to you, Sarah, to really assess what some of the gaps are in terms of the problems identified within our mental health care system, and also what in some of the solutions that have been proposed in the plan.
Yeah, I think that I know that I was positive in kind of the introduction, but I definitely echo what my co-presenters are saying around gaps. And I think that as much as I am super supportive and excited about the fact that the plan is articulating the problems in kind of a prevention and promotion and earlier intervention way, I also think that there are definite gaps in terms of, I didn't notice a lot of mention of family in the plan, and I think that that is a massive gap in terms of support for the supporters of loved ones who are struggling with mental health and substance use. In terms of programs for families, support for families, what is that going to look like? There wasn't really a mention of families at all. I think in addition, the plan seems to be more kind of earlier intervention and prevention, and there wasn't a lot of mention in the plan, which I think Lesley spoke to from her area of expertise, but a lot of mention in the plan about how we are going to support people who are experiencing serious mental health challenges and substance use challenges and who are more marginalized in their lived experience. And I think that was something that I didn't really see, and is definitely a massive gap. I think that this is maybe not a gap, but something that I was a bit confused about and have a bit of criticism about is that in the plan they said that they are going to develop peer support worker training resources, and I think that my opinion is that in our mental health system we are often reinventing the wheel, which is not necessary, and there are so many organizations who have peer support training resources, who are employing peer support workers who have been doing this work for years from a grassroots perspective and are doing amazing work in terms of employing people with lived experience. And so I hope that the system doesn't put a bunch of resources towards reinventing the wheel and developing training resources for peer support workers provincially when there are already people that are doing this work, and they should harness that expertise. So maybe that's not as much of a gap, but it's something that I definitely notice as it stood out to me as something that maybe doesn't make the most sense.
Yeah, I think that's an excellent point. Is we need to leverage what's already working well in our province and the expertise that already exists, and that really speaks to, again, funding priorities. It's making sure that we're putting money in the right places to really build up the system well. Now I'll turn it over to you now in terms of gaps. What have you identified in the problems, specifically with regards to mental health and substance use care for Indigenous communities, and the problems identified and the solutions proposed?
So a lot of my thoughts, again, are consistent with those of my two fellow panel members. But overall, looking at the plan, one of the things that I noticed is, I think it's very important that Indigenous people or Indigenous-led solutions are, a core part of this plan. So one of the 4 identified kind of priority areas. At the same time, what can sometimes happen is that we end up being kind of placed only within that area, and there is a risk that people will fail to recognize that our needs extend into those other priority areas as well. So, for example, the mental health and addictions care of youth, children and youth, having better access to care, and those types of things. And obviously, we are disproportionately represented within the opioid crisis in British Columbia. And we also, on various indicators of health, in some instances, show poorer measures of mental health. So I think that's sort of the tension, is that we need to be a key piece of a mental health and addictions plan in this province. At the same time, we can't be confined to just, the Indigenous-led solutions, because many of the solutions that are available to any resident of British Columbia should be, by rights, available to any Indigenous person in this province. With regards to specific gaps, I won't reiterate what some of my colleagues mentioned. There were certain populations that I think are important for BC First Nations that weren't necessarily addressed in this plan. For example, we are disproportionately represented in the correction system, and I know that again, when it comes to mental health and addictions, it's very difficult for people to become part of that seamless pathway to mental health and addictions care, especially upon discharge from a correctional center. And the other population that was not really, I didn't see a lot of mention, was the people who may be homeless or vulnerably housed within the province. And it was mentioned, so it's not really a gap necessarily, but it always, I think, needs particular attention, is the people who live in very rural and remote communities. So it's very difficult to access these pathways to mental health and addictions care. The other major gap that I noticed was there wasn't a lot of attention paid to health human resources. So healthcare providers, the whole sort of spectrum, all the way down to peers. And I think we could talk about that maybe later on the panel, but I just wanted to point that out as something that that I noticed in the document.
Thank you. Now, I feel like you bring up some great points about, bringing that Indigenous lens throughout the whole system, about access for marginalized populations, and about kind of building out our human resources, specifically around peers involved in the system. The next question I'm going to turn over to you, Sarah. What do you see as some of the first steps towards connecting services and connecting people to services in community settings? Because the plan really acknowledges that there is fragmentation, lack of consistency in oversight and delivery, but its main solutions are just team-based primary care and an online portal, which may not be accessible to everyone. So how do we begin to address that and really connect people to the services they need?
Yeah, thank you, Amelia. I do appreciate that they acknowledge that our services are fragmented and inconsistent, and I do think that the existing integrated primary care teams and community health centers do crucial work for people who are looking for support. I also think that the online portals for individuals in remote and rural communities is a good step towards access, which I guess is one of the focuses of the plan. All of that being said, I think that this plan will not address access and integration for everyone. And I think that in terms of supporting marginalized populations, the proposed solutions are not only very medically focused, but they're also putting the responsibility on the individual to access the services. So either go to a place where they can get access to an online portal or get connected to primary care homes or community health centers. I think that the plan definitely has some gaps in terms of supporting this population of folks. And I think that there's no mention of other amazing things that are already happening to support people that are more marginalized in terms of their housing situation, or many of the other things that my co-panelists have mentioned. And I think that that could be solved through outreach into services, having services offered to folks where they are staying, maybe in shelters or supportive housing, meeting them in the community, meeting them where they're at, meeting folks who are in the correction system, instead of putting the responsibility on the individual to attend the services. I think that this would bridge the gap that is not being addressed in the plan right now. I think that peer work obviously is my little soapbox, and I think that the plan to me makes it seem like peer work and peers working within the system is kind of separate. They mentioned resources for training peer support workers, and they also mentioned having peer coordinators provincially, which sounds good, but I think having peers integrated on our teams, and having integrated teams, period, I think is a huge way to have people, which includes family peer support and a variety of different things, is a way to connect people on different levels. I think people engage with our system in different ways, and if folks have maybe some mistrust in the system, or have had some bad experiences, or for a variety of reasons aren't going to connect with a certain person on a team, I think having integrated teams of various interdisciplinary professions will give people the opportunity to connect with somebody on that team, and then everybody can work together to best support that person in a wraparound fashion. And that's not really spoken to. It's more about kind of peers are going to be separate, or other professions are going to be kind of separate, and folks are going to have to go to those primary care services as kind of an entry point into getting support. I think that there are many bridges to getting people connected to the support they need and deserve, and I think that we need to break down barriers and silos for people and actually go to where they are. And I think that Lesley spoke so well to this in terms of needing more recovery homes for folks to go to, and more beds, but also we need to have the services for people in those recovery homes embedded. And so we're breaking down barriers and making it more accessible for people, more streamlined. And I think that the plan is focused on integration and access, but it's not really addressing what that's going to look like for people that are not necessarily going to reach out.
Thanks, Sarah. I feel like you make a really important point around meeting people where they're at and really leveraging the expertise of peers and having them involved in team-based care. I know that's also very important in the substance use community. So I'm going to turn the next question over to you, Lesley. The plan really identifies the need for addictions care on a continuum from primary care, withdrawal management, and counseling, to hospital outpatient services and treatment beds. But we know right now in the province, a lot of that doesn't exist. And you've kind of touched on that previously. But what needs to happen right now to ensure people have access to the addictions care they need? And what should the government invest in? Where should they put their healthcare dollars?
There's so many places. I don't even know where to start. But from the stories that I hear, which are many, I've heard the stories of 1,300 people across Canada right now, families. And I think, Sarah, you touched on this too. Families need to be supported. Families need to be supported in the care of their loved ones who are struggling. We're recognizing the need for funding and support for families who are living with a loved one who has a permanent brain injury from overdose. We have a whole, I call it an army of people who are going to need support now and in the future. Families are caring for these folks without support. So that's one place. We have to look at where we're at right now in this crisis and support families in their needs. It has to be frontline. So if the province wants to put some money somewhere, and I'm not sure if this is the purview of the province or it's the BC College of Physicians and Surgeons, but family physicians need to be trained in addiction medicine, and they need to be trained in all the pathways after the individual comes into their office with with addiction. I mean, this is my personal story. My son did that, and the doctor fired him as a patient when he learned he was addicted. I know that's extreme, and that's probably not the case for most physicians in BC. But I know that physicians need the support and education around treating their patients and have their patients go in the right direction. So what is that direction? Well, there's a big gap right there. The other thing I want to mention, that people are incarcerated. So many thousands of people are incarcerated for minor drug crimes or crimes associated with drug addiction. So many of those people have mental health issues. So when they're released, there needs to be a safety net. There needs to be a continuum of care after people are released from an incarceration that is due to their health issue. I see this as a highly, highly unfair and sad. I know of families whose loved ones have died coming out of being incarcerated because of their vulnerability to the street drugs. So again, I look at the deaths. I look at the gaps that are so sad. Another place where I would like to see the province put money is in the emergency, in hospitals, in the emergency wards, where people who have either overdosed or who have showed psychosis or other illnesses because of drug use, not having the facilities to again have a safety net for those folks. They get released because there's not enough staff or there's not enough beds for people in that state, and they're released out to the care of their family or onto the streets. This perpetuates the problem. I actually forget what the question was, but this is really where the province has to put their money where their mouth is. The continuum of care has to be unsiloed. It has to be accessible. If it's portals, then people need to know how to use those portals. In rural and remote communities, which I've had the privilege of visiting over this past 6 or 8 months, they're so desperate for connection, and their frontline workers and their service providers are so desperate to have more resources, to know what to do. There's so many places where money and expertise needs to go. I'll leave it there.
Thanks, Lesley. You were right on the money the whole time. Really just kind of addressing where health care dollars should go. And I think you really answered that beautifully. The next question I'll address to Nell. And you've touched on this already about the Indigenous LED solutions being incorporated through different components of the plan. One of the ways that the plan promises to do this is through meaningful partnerships between government and Indigenous communities. Can you comment on what the hallmarks are of a meaningful partnership and what is needed to adequately address discrimination that already exists in our system and to expand culturally safe services?
Sure, that can easily be covered in a few minutes. I'll do my best to give some overarching ideas. So firstly, the first part of the question was, what are the hallmarks of a meaningful relationship? And I think in this instance, when it comes to Indigenous people and BC First Nations people, in order to begin to have a meaningful relationship, both parties have to come forward to enter into that relationship and develop a rapport with each other and trust. And part of doing that is having open and honest conversations with people, and also acknowledging the harms that have happened in the past. So across this country, for example, we do have a history of colonialism and historic harms, including the residential schools, the Indian Day schools, the 60 Scoop, child welfare issues, etc. So there is a lot there to keep in mind as we move forward. So once we can have those direct, open, honest conversations, then we can begin to work on a relationship that involves, I hear the phrase nation to nation used a lot, but here this would be more of a provincial to nation to nation with BC First Nations and our leadership, for example, at the First Nations Health Authority. And, that can be really challenging for people who have, mental health leaders or addiction leaders who have worked in this province to kind of enter into that sort of true equal power sharing relationship, which hasn't historically necessarily been there. And so that takes a bit of time to become used to. The other thing I think that's really important in a meaningful relationship is reciprocal accountability. So, there are, for example, in the priority actions, there are a number of different actions in the Indigenous focus with some indicators, but the indicators, are very kind of general and sort of high level. So they're not specific ways on which we measure outcomes, but that would be part of the accountability, is that we look to see as this pathway moves forward, both on an annual basis or the 3-year mark that's outlined, and also that this is a 10-year vision, that we look to see that, there are significant ways that this is moving Indigenous health forward, First Nations health forward. But there is reciprocal accountability, which means that we, in this instance, as BC First Nations and people who work on behalf of and for BC First Nations, have that accountability back too. So we have some real questions that we need to ask ourselves about how we move forward. And I can give you a whole number of examples of that. But for example, we, as a quick example, we're having discussions within our communities around what does harm reduction mean, or the debate. It's not really, I shouldn't say it's a debate, but the spectrum of harm reduction and abstinence as being part of that spectrum, rather than it being a versus situation. So we're having discussions on that. So that relationship needs to be there. And then secondly, what do we do to adequately address discrimination in our current system and expand culturally safe services? I mean, this is, again, one of the priority areas that's been identified, and we have done some important groundwork in that regard. So for example, here in British Columbia with First Nations Health Authority, we have signed declarations of commitment to cultural safety and cultural humility. With different bodies, with different associations. So for example, the Doctors of BC and all the regulatory bodies, as well as the regional health authorities and the provincial health authority. So those are important, but that's important groundwork that needs to take place. But when we really talk about, how do we address discrimination, we're looking, because reducing discrimination is so important to improving access to services. People are going to be very reluctant to come forward, and not just Indigenous people or First Nations people, but people who are discriminated on any level, on any dimension, are going to have a real difficulty coming forward to seek help for mental health issues or addictions issues if they feel that their expectation and their previous experiences that they were discriminated against. I think there's a lot of recommendations in, for example, the Truth and Reconciliation Commission's calls to actions. There were 93 specific calls to action, 7 specifically in the area of health. So these include things like recognizing traditional healing, cultural practices as important parts of healthcare, and having the Western trained healthcare providers recognize that and be accepting of that, be open to that. We still hear a lot of conversations, around the province of, I speak mainly on behalf, from a physician's perspective, because I'm a physician, but patients or clients being told that, that if they don't want to follow this particular recommendation or prescription from a physician, well, then they can just go away. Rather than working towards setting up a plan that's, perhaps inclusive of traditional healing practices. We also need to, as First Nations people in this province, we need to participate more in the healthcare system. So, I'm involved with a lot of initiatives here at First Nations Health Authority that are working to support and train more Indigenous healthcare providers in this province so that we can, we are underrepresented in this province so that we can achieve proportional parity, so that we can actively participate in the care of First Nations and Indigenous people in this province. And then with discrimination, there are recommendations around, say, undergoing cultural safety training, but there are cautions in that. Sometimes people can be led to, to think that, once they've completed a 16-hour course in cultural safety training, that automatically, makes them culturally safe moving forward, and that they don't have to continue. That's a lifelong process of developing and working on one's cultural safety and humility. And so ultimately, I think, we can work on, some of the newer graduates, we can have it be part of their curriculum, have them exposed to Indigenous health issues and larger issues, including, sort of the historical determinants. But partly what we hear is that, the cultural safety initiatives also need to reach the people who are working in the healthcare system now, or even the people who've been practicing for many, many years and who are sort of out of reach at this time in terms of cultural safety training. So, some of these people who, for example, are veterans of the healthcare system, may not be quite as open to engaging in this kind of way, this newer way of practicing, this modified way of practicing, of acknowledging, for example, traditional healing than, say, newer graduates. And we haven't talked about that a lot necessarily, because I think, some people who have, been working in the field for many years may not be all that willing to sort of, take that time of self-reflection and self-examination of their practice and whether or not they have been discriminatory. And that could include things just like implicit bias. So in some ways, not even realizing that they're discriminating, but that they've practiced that way for so many years. There's so much to say on this topic, but I think I'll have to stop there.
Thanks, Nell, and thanks for giving the question, a really fulsome response. I really appreciate that. We're running short on time, so I'm really going to encourage our attendees to write in questions for our panelists. You can do so just by writing into the question panel. You should find it on your right. And if you'd like it addressed to a particular panelist, just write that in there, and I'll make sure that it's asked to them. I'm going to jump into some of the questions that we've already received. And I'm going to keep this one open to all the panelists. It addresses kind of social determinants of health. How do you think the plan fits with what we know about the social determinants of health? Could there be stronger connections with the poverty reduction strategy, housing investments, etc.? Lesley, do you want to take a crack at that one?
Well, I do. And what we always say is that nobody who is in the throes of substance use disorder can recover without a roof, a secure roof over their head. The report touches on housing. It doesn't give any details, but we know for a fact that if you are living out of secure or reasonable housing, it's impossible, I would say, to get well. I know that's kind of a sweeping statement. So that, I don't know, I'm not really sure of the details of how the welfare system works, but people who are vulnerable need a living wage or a living amount of money to move forward into wellness. And so we have to attend to all those folks who, as do other countries, who are marginalized for whatever reason. If that's, I think that was the question. I'm not sure, but certainly it's access to healthcare. It's access to non-stigmatized healthcare. It is access to proper meet the person where they're at treatment and medication, low barrier, all those things. I mean, it's pretty simple when you think of what people need, but it is complex to figure out how the funding, I just always go back to that, it's the funding. We know what to do, we have the evidence, but we need to support that evidence with action, and that action requires funding priorities.
Thanks, Lesley. And I really like how you tied together the importance of having a foundation, having housing in order to be able to access services in the first place, and how those two things really come together. Our next question I'm going to address to you, Sarah. How do you think the affordable counseling should be delivered in community? What are some of the characteristics you would see as a successful counseling program that's accessible?
I think that right now, from my experience working in Vancouver, and I haven't had any experience working in remote and rural communities in terms of what access to counseling looks like, but in terms of what happens in Vancouver, there are very few agencies that actually provide free counseling. So it's all sliding scale counseling, and the wait lists are incredibly long. And so I think that first priority would need to be that the access to counseling would need to be accessible within a timely manner. And I don't know what that would look like in terms of actually creating a program, but I think that that would need to be incredibly important, because I think when people reach out for support and they are looking for counseling and they feel readiness in themselves to access counseling, we can't tell them that they need to wait 6 months to 9 months or a year in order to get connected to counseling services. I think that there is also not a lot of trauma-specific counseling, and so there would need to be counseling that is not only trauma-informed, but also focused on supporting folks to work through their trauma, because I think that there's more general counseling out there, and I think that there's a significant need and gap in terms of folks that want to access trauma counseling and can't. I think that sliding scale counseling is important if folks have income in order to kind of triage the whole situation, but for the sliding scale to be reasonable. I heard about one service in Vancouver that charges hourly what a person makes hourly. So if they do not have a job, they don't have to pay. If they get paid minimum wage, they pay minimum wage for an hour counseling session. And so kind of focusing the counseling service on the person's ability, their socioeconomic status, and their ability to pay for counseling, and in order to kind of figure out where people are at, and also make sure that they are getting the services they need and deserve. I think that also from my experience being a person with lived experience accessing services, I think that the fit is really important as well. And so I think also not giving people need to have options in terms of getting to know somebody, and also having a choice in the person that they're connecting with, because they are sharing their story and their life with that person, and there needs to be trust and rapport and culturally supportive services, all of those things. And I think that if we tell people, well, this is what you get because it's affordable and or free, I think that that is not going to be supporting people in the way they need and deserve. And then it also may mean that people may get turned off of services and may not want to access services again. And so, yeah, it's definitely not my expertise in terms of building provincial programs, but I think those are some of my thoughts on working with people in the field for years, and just knowing kind of what is important from what I've heard, and also from my own experience accessing services.
Thanks, Sarah. I feel like you make a lot of really great points about making sure it's person-centered, meeting people where they're at, and truly accessible. Our next question is for Nell. So it's noted here that the plan doesn't really mention urban Indigenous populations, and this is a gap. Do you think that the plan offers enough options if urban Indigenous people are not connected to a specific community?
Well, there specifically was one area where urban populations were mentioned, and that was with regards to the funding being provided to build 2 new treatment centers based in urban settings. But you're right. I think a lot of the times people think, when they think of First Nations people in this instance, they think of everybody living sort of out of the big cities and living sort of in smaller communities, either in rural or remote areas. And that's not the case, actually. A bigger proportion of our people live in more urban settings, not necessarily giant, sort of cities like, comparatively speaking, like Vancouver, but like in smaller, like Kelowna, Prince George, etc. So, I think what this pathway tries to acknowledge, and identified it both as like kind of a good thing and as a gap, because I think we need to be really mindful, is that when it comes to Indigenous people accessing mental health and addiction services, really the point is that people should have the ability to choose for themselves what they believe would be the best course of treatment for them. And if that is accessing traditional healing, cultural practices, on the land treatment, then they should have ready access to that no matter where they live, whether they live in a remote community or whether they live in an urban setting. But also that if they choose to go the Western-based route or a combination of both, that the system should be flexible in allowing people to do that. And I think one of the barriers to helping that move forward, and I think we talked about it just at the beginning of this question period, was the ministries being siloed in a way. So we need to work in a multidisciplinary fashion across ministries in order to make this happen.
Thanks, Nell. So we're coming up to the end of the webinar, and I just wanted to end on a positive note and to really address our audience here today. And I'll go to each of the panelists in turn. If you could just say one quick comment of what the next step is and how people can continue to advocate for improved mental health care and substance use care in our province. So Lesley, I'll start with you. So one quick comment to end us off.
We all need to connect with our legislators and the politicians. We have to let we have to be political here, and we have to let the leaders of the parties know what we need and what we want, and ask what their platforms are and how they intend to do that. It's life or death.
Thanks, Lesley. Sarah, I'll turn it over to you.
I think we need to keep having conversations like we've had today. I think we need to connect with each other and hear from each other. I appreciate the opportunity. I also think that we need to build on existing organizations that are doing amazing work, existing grassroots movements that are doing the work that needs to be identified instead of reinventing the wheel. And I think that we need to listen to people with lived experience and families about what they want this to look like instead of it coming from a top-down approach.
Thanks, Sarah. And now I'll give you the last word.
Just to follow up exactly on what Sarah said, I think I'd use a quote from the Truth and Reconciliation Chair, Senator Murray Sinclair. We have momentum behind us now, but when it comes to reconciliation, it will not be achieved if one side believes it is based on the recognition of rights and the other side believes it is an act of benevolence.
Thank you all so much. Thank you to our panelists, and thank you to everyone who joined the webinar today. We're right on time. It's exactly noon. A quick mention before you sign off is that there's a short survey in a pop-up window when the webinar concludes. We greatly appreciate if you would take a minute or two and fill out the survey. Your feedback will help us design future policy webinars that are of interest to you. Okay, that's all from us here. Thank you, everyone. Enjoy the rest of your day.
Thank you.